afternoon.
Next
My
speaker.
presentation is on outcomes of surgical management of retained subfoveal PFCL and vitrectomy. Myself, Muthu Krishnan. I'm a consultant at Arund Hospital, Madurai. Subretinal PFCL is a rare but serious complications following VR surgery, and the incidence is around 1%. The toxic effects of PFCL retention are explained by mechanical compression of the retina and chemical toxicity because of the high oxygen carrying capacity of PFCL causing vasoconstriction. On OCT, subretinal PFCL demonstrates an acute angle between the RP and the neurosensory retina at the base of the droplet. There's an elevation of RP hyperreflective band, RP disorganization, disruption of ELM and ellipsoid zone, and retinal layers above the subretinal PFCL droplets are ill-defined, as seen in this image. So the aim is to study the outcomes of surgical removal of retained PFCL in patients with subfoveal PFCL following vitrectomy. So this is the largest series of cases of surgical removal of subfoveal PFCL, and hence the study. It's a retrospective observational study done at the Department of Vitreoretina at Arund Hospital, Madurai, over a span of 1.5 years. The primary outcome measured was improvement in corrected distant visual acuity, and we also looked at restoration of foveal contour, restoration of outer retinal layers, and complications. Inclusion criteria was subfoveal subretinal PFCL without any retinal or choroidal detachment, operated by a single surgeon with at least 6 months of follow-up. Corresponding exclusion criteria were maintained. 19 eyes of 19 patients with retained subfoveal PFCL, that was a methodology, over 18 months. Baseline parameters for visual acuity, intraocular pressure, number, duration, and size of the PFCL bubble, and OCT parameters. These parameters are studied at 2 weeks, 3 months, and 6 months with complications. So let's have a look at the surgical technique. The first image shows subretinal bleb being raised, and the third image shows a large bleb raised with, by injecting balanced salt solution with 41 gauge needle. That's the bleb raised. PFCL is injected at the posterior pole, and subfoveal PFCL is displaced using Tanos, and the PFCL is removed by extrusion cannula through a parafoveal retinotomy. The preoperative and postoperative image of patient is shown below. So having a look at the baseline results, so age 54 years, gender 58% male and 42% female. Pre-op visual acuity was 1.8 logmar preoperatively. And indication for primary surgery was 79% regmatogenous RD and 21% tractional RD. The median duration of retained PFCL was 3 days, 1 to 50 days range. So number of PFCL bubbles was solitary in 68% and multiple in 32% patients. Size of the bubble ranged from 270 microns to 1,270 microns, less than 500 microns in 2 patients, 500 to 1,000 microns in 11, and more than 1,000 micron large bubbles in 6 patients. So as we can see in this graph, preoperative visual acuity was 1.8 logmar, and post-operative at the end of 6 months was 0.8 logmar. So this shows a statistically significant improvement in the visual acuity at a post-operative period of 6 months. Comparing duration of retained PFCL with the visual acuity at 6 months, 0 to 3 days retention of PFCL in 11 patients and corresponding to median visual acuity of 0.8 logmar. Similarly, 4 to 20 days retention, again a 0.8 logmar visual acuity was maintained. And when this was more than 21 days retention, there was a mild drop in the visual acuity to 1.1. However, there was no statistical significant difference between these 3 groups. Restoration of foveal contour was achieved in 90% patients, and there was a localized atrophy of outer retinal layers, as seen in this image, and photoreceptor loss in all patients. Residual parafoveal bubble were noted in 2 patients, and both these patients had multiple bubbles to start with. Complications encountered are macular hole in 1 and submacular hemorrhage in another patient. So what's the role of OCT? OCT helps to localize the PFCL bubble as well as the multiplicity and demonstrates the dimensions of the bubble, and also helps to differentiate from subretinal fluid or subretinal oil, as a PFCL has a distinctive bubble beneath the retina, whereas SRF would be a dome-shaped elevation and subretinal oil is a shallow elevation in a wide area. So several techniques for surgical removal of PFCL. So direct aspiration with various cannulas, or displacement of PFCL and removal with retinotomy, or just a peripheral displacement beyond the arcades without removal. So significant recovery of visual acuity. So what's the ideal timing of PFCL removal, having discussed all this? So significant recovery occurs with a PFCL removal as long as 3 months post-operatively. The mechanical barrier effects and the toxic effects may contribute to limited visual acuity. So incomplete fluorination of hydrocarbons during production of PFCL and fibroblast proliferation is supposed to cause limitation of visual acuity. Perfluorodecalin is more toxic than perfluorooctane. We use perfluorooctane in our study. An important factor is timely surgery. So before I conclude, this is the largest case series of surgical removal of subfoveal PFCL. Significant recovery can be expected till a period of 3 months post-retention. Mechanical barrier effect and toxic effects may contribute to suboptimal outcomes, and the macular status before the primary surgery could also have a bearing on the ultimate visual outcome. Thank you.
Thank you, Dr. Muthu.
Yes. Did you try doing a microperimetry in these cases?
No, ma'am, we have not done a microperimetry.
Because probably you could then correlate even the visual recovery with the, the toxic effect of the PFCL that happens when it's in the subfoveal area. Because otherwise it's going to be very difficult to really make a judgment, like you mentioned, that even if till 3 months, because that could just be a physical barrier over there which could be causing a blockage in the visual recovery. But after you've done the removal, did it have any long-term effect on the underlying layers?
Long-term removal, till most of the changes were noted at 3 months, and up to 6 months it persisted.
So next we have Dr.
Thank you, ma'am. Thank you, sir.
Shweta Singh.